Bandura's work was very influential and is still very valuable in terms of if you're in a treatment clinic or something, giving people self-efficacy measures around high-risk situations gives you an idea where you need to work to get the person's confidence up, deal more effectively with negative emotions or whatever it happens to be. But if the person has an ineffective coping response, just like the guy with his wife feeling decreased self-efficacy, I can't handle this, positive outcome expectancies for the initial effects of the substance. Well, if I have a drink, I can be more relaxed, I can handle this kind of thing. Will often precipitate a lapse. Now, in relapse prevention, we make a distinction between a lapse and a relapse. The disease model, any drink is a relapse, or any use of any drug. But we make a distinction because a lot of people do have lapses where they have 1 or 2 cigarettes for whatever it happens to be, and then they're able to get back on the wagon again. Whereas other people kind of fall totally off. And one of the things that seems to determine whether people go totally off the wagon is whether they have this abstinence violation effect. This shows I can't do it, I have no willpower. It's like Oprah, biological, fat wins. I can't do it. And of course, what Oprah did later was she started to talk about lifestyle and what she needed to do to get more relaxed and take care of some of the stress in her life, and that made her put her back on the wagon again. She felt she was handling her weight problem much more effectively. So if we have somebody who falls off the wagon, we want to continue to work with him or her, whatever it happens to be, because this is a time when people drop out of treatment. And when I first started doing treatment myself in terms of working with alcoholics, it was at Napa State Hospital when I was on my internship in California. And people kept falling off the wagon, and I'd work with them, and then they'd start drinking again. And I went to the director of the program and I said, why aren't we teaching people more about relapse? Because it looks to me like 70 or 80% of the patients are falling off the wagon. He said, no way. Because we talk about relapse, it's just going to give people permission to do it. So we don't want to talk about it, so we just ignore it, in terms of we want everybody to be successful. But I'm saying, well, why do we have fire drills and things like that, right? I mean, we need to teach people if they're in a situation where they need to do something to keep them alive, let's do it. But there was a lot of resistance. In fact, I just gave a talk a week and a half ago in Germany, Tübingen University there. And the guy that introduced me was a psychologist working with alcohol and drug treatment programs. And he said, when your book first came out in 1985, he said, I had a copy of it. I was working in this treatment center. We kind of had to take your book and read it under the table. Because in that treatment center, if you were relapsed, you had any relapse, you were kicked out of treatment. And you were saying in your book, no, you got to work with these people and keep them going and so forth. So he said that was a big controversy. And it still is in terms of what we do with relapse issues, what we teach people. So, what kind of results, just to finish up here, are we getting with relapse prevention? One of the first studies we did was at the Seattle Veterans Administration Hospital with chronic male alcoholics. And we asked them if they wanted to be in the study, and they could either be randomly assigned to relapse prevention, called skills training here, or there was 2 control groups. One just got the regular hospital program, disease model, abstinence-based program. Or they were in a sort of an insight-oriented group talking about why they might relapse, but nothing to do with how they're going to cope with it if it happens. And so those 2 control groups didn't differ significantly, so I just combined them here. So what we're getting are, we looked at following people up 1 year after they went through the program. If the people in the relapse prevention, what we did was got them together in groups, talked about trigger situations that they knew about or that they had experienced, and tried to teach them how to cope more effectively with that. So like if anger was a big trigger, anger management training we would do. If anxiety was a trigger, trying to help them relax and do relaxation training. If it's social pressure, how to talk to your friends and be more clear about that you don't want to go back and what you're going to say to them. So it's mainly a cognitive behavioral rehearsal of different coping skills that we taught them. So they came in twice a week for 4 weeks. So what we're getting at the end is like less days of continuous drinking. The overall relapse rate among this pretty chronic male group was about 85% of the men. had at least one drink during the 1-year follow-up. And that's pretty typical for most alcohol and drug treatment programs. The relapse rates run around 80 to 90% of any use during the year following treatment. So here people were able to stop more quickly. They had fewer days of continuous drinking before they were able to stop. Number of drinks consumed was significantly reduced, about a fourth as much compared to the control condition. Number of days intoxicated was significantly reduced as well. So we knew what their weight was, and we could look at their blood alcohol level and see if they were above the 0.05 legal intoxication level. And they had more days of controlled drinking without becoming intoxicated. So from a harm reduction perspective, these are positive results. And if they do fall off the wagon, they're not falling off as seriously. They're able to get back on track more quickly than people in the control group. However, we don't get higher abstinence rates. Abstinence rates were pretty low. It was across the board. And that's generally what we're finding when we do reviews of relapse prevention overall. We're getting lower relapse rates, but not higher abstinence rates. So for example, here's the aversion findings that I was telling you about. To 3 months, in the yellow down here, percent baseline drinking. They were drinking significantly less than the control group here. They stayed about the same 1 year after the 3-month follow-up. And we can see that the aversion group basically rebounded, or they're drinking significantly more than the control group. Whereas with relapse prevention, we get a different kind of effect. They're drinking a little bit more in the beginning, but they drink less as the year goes by compared to the control group. And this has been called the delayed emergent effect by Kathleen Carroll at Yale and so forth, people that have evaluated relapse prevention. And that's basically what they're finding. And if you're learning a new skill, you could think about learning to ride a bicycle or something in the first place, you're going to make more mistakes because you don't really practice enough. But as you go along and you practice your skills, you get better and the results improve. Rather than aversion or doing something and it's wearing off over time. So Kathleen Carroll, in her first review of 24 randomized controlled trials looking at relapse prevention, basically finds it does not usually prevent a lapse better than other active treatments in terms of abstinence, but it's more effective at relapse management, delaying the first lapse and reducing the duration and intensity of lapsing. And effective in maintaining treatment effects over longer term follow-up measurements. So she was the one who coined the phrase delayed emergence effects. We should get greater improvement in coping over time. And overall found it to be more effective for more impaired substance abusers, including those with more severe levels of substance abuse, greater levels of negative affect, and greater perceived deficits in coping skills. So she was one of the first that did a review of what's going on with relapse prevention. And then Irving and others in the Journal of Consulting of Clinical Psychology came along a couple of years later, looked at 17 other controlled trials, found moderator variables that could reliably impact the outcome, show you what those are, and then results indicating that RP is highly effective for both alcohol and substance abuse disorders in their conclusion. And the moderator variables that they found was you get better results with group-based format than individual treatment. Because I think if you're in a group, just like in AA, when you're in a group and other people are learning from what you're doing and you're learning from what they're doing, it seems to be more effective in terms of learning the process of how to cope.